Welcome to the APAP podcast. My name is Rhea Votipka, and I'm a nurse practitioner at Leahy Hospital in Burlington, Massachusetts. Today's podcast is going to sound a little bit different because it is hosted by the APAP Critical Care Committee, of which I am the current chair. A little bit about me. I have been a nurse practitioner for almost 10 years and primarily have worked in medical ICUs. I'm really passionate about education as well as ultrasound and love teaching POCUS and doing all things POCUS. And I've actually been involved in APAP since its beginning. I've been a founding member and board member and have been really excited to see the progression of APAP through the years. And today I have been given the privilege to host a podcast with one of my colleagues, Sue Stempek. She is a really amazing PA that I've had the pleasure of working with. And we're going to be focusing on the role of APPs in research. Sue was recently involved in the PREOXI trial that was published in the New England Journal of Medicine. And today I'm hoping that by speaking with Sue, I can inspire more APPs to be involved in research. A little bit about Sue. She has been a PA for almost 20 years and has worked in the pulmonary and critical care medicine field. She's currently at Leahy Hospital with me in Burlington, Massachusetts. And she has fulfilled a lot of really important roles throughout her career, including being the director of APPs for Leahy Hospital. She's also been the executive director of CMO Affairs and Capacity Management and is currently the vice president for the Hospital at Home program, which she had a major role in creating within the Leahy system. Additionally, she's played an integral role as an APP representative within the College of Chest Physicians, and is heavily involved in education and research. She's an exceptional role model, and I've had the privilege of learning from her both academically and professionally, and I'm super proud to have worked alongside with her. So Sue, thank you so much for being here today.
Thank you for having me. This is great.
So as I spoke with you prior to beginning this podcast, the goal of this is to provide a starting point for those who are interested in research, or hopefully this can ignite some interest in doing research. And I wanted to start by highlighting the recent article that you were involved in, or the recent research that you were involved in with PREOXI. Can you begin by doing a brief summary of PREOXI and kind of talk a little bit about your role within that study?
Yeah, absolutely. So I think this is a great topic. And as you are, Rhea, I too am passionate about the role of APPs and all the things that APPs can do across the care continuum. And I think the opportunity for us all as APPs to contribute to research is really sort of underrepresented, right now today as we have this conversation in 2024. So I hope that describing my experience can help spark some interest for colleagues and also call it multidisciplinary colleagues. So our physician colleagues can sort of recognize what we can uniquely bring to the table. So the study that you referenced, PREOXI, that was published in June of this year, was a multi-center randomized trial evaluating pre-oxygenation technique prior to emergency tracheal intubation. So patients were randomized to face mask oxygen, which was most commonly a non-rebreather, versus non-invasive positive pressure ventilation at 100% oxygen to evaluate the difference in and that this trial was done a number of sites. I had the privilege of being our site principal investigator. My relationship and our relationship at Leahy with the Pragmatic Critical Care Research Group has grown over many years, and beloved physician colleague of ours who passed away a couple of years ago was the initial site principal investigator. And we had done 2 other trials with this group prior to this one. And so the group, when Dr. Dargan passed away, had asked me to continue his legacy, given my participation and another colleague of ours, Joanne Wozniak, who you know, so that we could continue our contribution from Leahy to this body of research in emergency airway management in the ICU. So of course, we definitely wanted to continue that. And so as you know from our operation, but for all of the listeners, we have a medical ICU setting where APPs are part of the 24-hour care team. And our APPs do airway management, but mm, it is also my strong feeling that no matter what setting you work in, whether you're an APP who participates in airway management or you're an APP who may be participating in the patient care but not doing the procedure yourself, the value knowing the evidence base is similarly impactful to the patient. What I mean by that is throughout my career as a pulmonary and critical care PA, there were times when I didn't know how to perform an intubation procedure, and then I was taught by many high quality airway experts during my career. And so I think contributing to the evidence base with lots of frontline knowledge of how the procedure should go, and then being able to learn from both doing the study, the results of the study, and then really thinking about implementation. We're in a unique position as APPs to do that. We're at the bedside again, whether you're the operator or not. And I think being able to sort of execute the evidence matters a lot, and we may have a unique view in that regard. Most of the operators, though, to be clear, in the study were fellows, so physicians who were training in the field of critical care. And then our site contributed quite a bit of APP operators in the data, which is great, and we're very proud of that. And I also just need to really compliment the Pragmatic Critical Care Research Group for being welcoming from day one of my capability and my colleague Joanne's, and they have other sites where APP contributors as well, that it is they've welcomed us the whole time. It was never a question as to whether we could bring value. Um, yeah, so that's sort of my summary of why it's been great and what the study evaluated. And many of you may know the results of this study, but there was a very significant difference in the oxygenation provided by pre-oxygenation with non-invasive positive pressure ventilation versus face mask oxygen.
Yeah, it was really awesome to be involved in that and see it unfold in real time and get to experience your role within that and getting your messages every single day to remember to enroll people. I don't know how you guys sent this text twice a day, every single day. It was really great. And I don't feel like we missed many people that could have been enrolled in this study. You guys did an awesome job.
Yeah, thank you for that. I think you bring up a really important point. That something that I think we as APPs are really good at, which is just getting things done, right?
Mhm.
So a 24-hour critical care trial is actually pretty hard to execute, especially when the opportunity for enrollment is in real time and could happen anytime in that 24-hour continuum, right? So as the principal investigator, it was my responsibility to make sure that we had a system
Mhm.
to enroll eligible patients
Right.
24 hours a day. And that required essentially real time communication with our frontline staff. And so Joanne and myself and some others on the team figured out a system by which we did that from day one of enrolling until
Yeah.
our last patient was enrolled. And we enjoyed bothering our clinical staff at least twice a day to check in, but it was really effective. And I
Mhm.
think there are sites, honestly, who have deeper research structure than we do at Leahy, but we were able, to to provide really great quality in our
Mhm.
data. And as you already labeled, miss, you know, zero to maybe few patients who could have been, who were candidates. So we're very proud of the quality of our data from this study. And I think it's just a daily real-time commitment to the consistency of that, because a critical care trial from the logistics required is certainly mm, not for the faint of heart, I guess.
Not at all. Not at all. Since you were bringing up some of your responsibilities as a principal investigator, can you talk a little bit more about what all that entails outside of,
Yeah.
texting members, making sure people are aware of the study and how to enroll people and who to enroll?
Yeah. So we have a few folks from our pulmonary and critical care division who are part of the Pragmatic Critical Care Research Group with me. And we together, but as you said, it's primarily my responsibility. participate in all of the updates from the network. So when we have a trial enrolling, we have regular meetings with all of the sites that are enrolling to keep our communication going. But also my responsibility included, all of the logistics. So IRB submission, working with our Office of Sponsored Research to make sure that all of the paperwork is up to date between the organizations, and multi-center trials, of course, require agreement between the organizations for this. So before enrolling the first patient, we had to go through all of the approval process and have it in place, and then receive the final approval from the central site to begin enrolling. So, what I found I had never gone through this process before as the principal investigator, and my colleague who had done it before for our site was great, but also just wanted to make sure that he did all the steps too. So I never learned all the steps before this experience. Again, back to the structure, the Pragmatic Critical Care Research Group, they answered every question in real time for me and sort of helped walk me through it. And so I think it's the lesson that I learned over and over as a PA is finding the right mentors and experts. A motivated person who wants to do something can get it done. I just had to learn. Everybody has to do something for the first time. And so I dotted my I's, crossed my T's, asked every question I could think of. And now I understand the process, in depth of, when the time comes to do it again, hopefully. So, certainly keeping up with the regulatory process responsibility prior to enrollment, during enrollment, and after enrollment completed, up to publication of the results.
So you talked about this being kind of your first time doing this role, and you learning a lot through the process. So what do you think that you did that went really well as you were doing this process?
I think that's a great question. I think consistency is probably the key here. And each organization, for listeners who are sort of thinking about, could I do this where I work? Every organization has different structure. And so you have to learn a little bit about the structure of the IRB and other arms of the research infrastructure that you may have in your organization. And then, what is required of you, who to work with. And then I found that just sort of keeping in touch and asking questions along the way, I was able to keep ahead of the responsibilities. I wouldn't be able to provide someone, step-by-step guide of how to manage it in your organization because it's a little bit different everywhere.
Mhm.
And then also there are different roles in every ICU to participate in research. And so I think there's probably a little bit of a variable answer of the best way to approach it in each organization. But to start, most structures would have a way to tell you sort of what you need to do. But I think consistency is probably the answer of how to sort of keep that learning going and be successful.
Yeah, absolutely. And even just being or being a member of the team that was getting information from you, I felt like that was very helpful for me because it always kept me aware of the study and aware of who might be involved in that. And having that open communication, to me it seemed to flow very easily as we were enrolling patients and doing this study within our organization. Um, what do you think, now that you've done this for the first time, what do you think you might want to do differently in the future or in future studies?
Yeah, I think good question. Our organization is on a journey to structure to support clinician researchers. So I think one of the things that I would love to figure out, and I've also talked with our emergency medicine colleagues in our organization about this as well, is what is a good way to sort of administrate, execute in a high quality way a 24-hour critical care trial? And those are really in the emergency department and in the ICU in terms of addressing patients that may be enrolled in a 24-hour way. And there are many different ways to address this, and want to sort of think further about how we can create that structure that maybe someday doesn't require the principal investigator to do something twice a day every day for the whole time. Um, but but I don't mean to reference that in a bad way, but actually just to be really transparent. And I think myself and other colleagues who are involved in this study in our organization, I think would say 100% over and over, it was totally worth it. In many ways, being involved in this research has been one of the most rewarding parts of my career as a whole. So, I think many of us sort of think about what makes me tick, what makes me get up in the morning. And I just deeply believe in the approach to this. Really enjoyed pragmatic trials. And so I think my responsibility, having understood the complexity of executing a trial like this, is to think about how we make systems a little bit more, to do it systematically every time, and maybe have it depend on the individual investigator a little bit less.
You talked a bit about just some of the personal pride that you gained from doing this. What other rewards have you seen as a result of this study, both maybe personally and professionally, as the study has been read more and become more widespread?
Yeah, great question. We are thinking about in the trial network about implementation of results, right? So we want to do really high quality studies, and we also want to impact outcomes for patients. And so I've had the privilege of working in both the community hospital setting and in an academic medical center during my clinical career, and those settings are pretty different. And so I've worked many times where the APP is sort of certainly the first responder to a patient, if the only clinician available. And so I have a deep passion for getting results like this to the bedside, not only to our academic medical center who had the privilege of contributing data and participating in this trial, but to hospitals that don't have research infrastructure, but the results are meaningful to the patients that are in their ICUs and in their EDs. And so, for me, something rewarding is I think the results of this trial were pretty meaningful in understanding something that can make the emergency tracheal intubation procedure safer for patients. And therefore, I really also want to think about how can we get this information to the bedside outside of the academic setting. Certainly, we have conferences where we can present results. We have podcast discussions, this one. So there are many multimedia ways to get results. But I think there are also, this is an interesting trial from the perspective of how do you do it, right? Not everybody has a ventilator that provides non-invasive ventilation. Some people need to do this with a separate non-invasive machine and then switch after the endotracheal tube is in. Those logistics are pretty different. The way that we at Leahy were able to execute, which was using the same machine, different mask.
Right.
So I think that is a point of pride and also a point of interest that I think, having trials where the results are, whether they're sort of quote negative or positive studies, and then really seeing those results actually implemented in the diverse states where we all this.
Right. As you were talking about that, I can only imagine what it would be like from the research perspective to get good data, get good results, and then not really see that show up in practice. I mean, we hear all the time that it can take, 10 years before from the research to be published and for the information to come out before it actually gets accepted into practice. So I can imagine that can be, I don't know if frustrating is the right word, but, when you see a good result and you want it to be adopted, but yet there's such a lag time in between that. Yeah. And so it'd be, I think, helpful in general within the research community if we could figure out a way to better translate the good result, the good outcomes, and actually into regular implementation and practice. And maybe APPs are the way to do that because, we're kind of that consistency a lot of times in units. And hopefully we're around more often, we're up to date on the research. And I know for myself and for others that we're heavily invested in our patients. And that's not saying that our other colleagues aren't, but it can be different for maybe attendings who are rounding for part of the day. And then they have a lot of other responsibilities going on, or for residents who are maybe on the unit for, a month at a time, and they don't really have they're already learning so much and have a lot more on their plate. And so APPs can potentially be that source to provide that consistency and really implement things early on.
Yeah, I totally agree. I think there's a really interesting consistency for the APP role. And as you mentioned, in many settings, attending physicians rotate through the unit sort of less frequently. The other thing that we've thought about a lot is our respiratory therapists play a
Mm,
huge role in implementing the results of this trial. And as we thought about teaching people how to participate in this trial in our organization, the medical director of our respiratory therapy team, support, and the leadership of respiratory therapy, we focused a lot on trying to make this as easy as possible for our respiratory therapy colleagues, help them. They were super supportive and really understood the why. So we wanted to make the logistics easy for the trial. That translates to we should make the logistics easy for them to do it when we want
right.
to use non-invasive for pre-oxygenation and the result or outside of enrolling in it, I should say. So that has been a great experience for us in our organization. But I think as we think about implementation, each organization needs to think about who is the multidisciplinary team that's identifying that a patient may need to be intubated, because that's sort of where the thought process should start.
Mhm.
Because this has a few more logistics than, just a non-rebreather, if you will. But if we, plan, we learned in doing the trial, right? You can affirm or deny what I'm saying. But really, as you're preparing for an intubation, if you put the mask and have the machine ready, not delaying the procedure at all. And I think
No.
there's some perception that this takes so much time and it's really hard to do. And of course, we had that conversation in our organization as well. And it just was not true. With the right preparation of the team, you can do both at the same time.
Mhm. Yeah, absolutely. I mean, hopefully you're doing your intubations in as thoughtful of a way as possible and, positioning your patient. So I agree with you. It's very easy to put the mask on and have the 3 minutes pass by and you're already doing all the things that you normally do. And so it really doesn't add extra steps per se outside of that initial putting on it. And then you don't have to worry about, holding a mask on somebody's face. And you obviously get better results than just, an on rebreather.
Yeah, and it's interesting, right? A couple points I would make about APPs in particular. In our organization, as you know, Rhea, but for the listener, APPs in critical care participate in rapid response and of the ICU consultation, admissions to the ICU. And that means we, the APPs in our organization, are often the first evaluator of a patient who is critically ill. That also means to me that we have the opportunity to shape the clinical plan for the patient. And
Mhm.
as we draw the corollary to the results of this trial, for me, what is if I'm doing that role, I would flag for my clinician colleagues in the ICU, hey, I need to bring a patient who may need to be intubated emergently. Obviously, we make the judgment of do we need to do it here versus there. And I think they're a great candidate for PREOXI, let's tell respiratory. And then as I'm doing nurses, APPs, physician that's in the ICU, we can be bringing the patient safely and then be preparing for or maybe even travel on bypass, depending on the situation. So I think super important for the first clinician evaluator to be really up to date on results like this to facilitate systematic implementation patients who are eligible.
Absolutely. Um, with our last couple minutes, I want to transition a little bit into talking about how we can encourage APPs to get involved in research and ask some questions that I had and hopefully other people have about APPs being involved in research. The first is, you know, where do you start? I mean, you were a principal investigator, but say there's somebody out there, they haven't really done research before. What's a good place to start if they're interested in being involved in research and maybe one day being a PI themselves?
Yeah, great question. So I think in terms of what can be done in research, it doesn't have to be a randomized trial, right? So I think what provides the most enthusiasm for doing research is something you're interested in. What's the clinical question? What really fuels you in something that you care about? And then thinking about, is the fit for that question an observational study? Is it a retrospective analysis just to sort of spark directionally where you might go? And then you might need to think about the structure to answer the question prospectively. What kind of structure do you have in your organization? And if you're in an organization, which many listeners may be, that has very little to none research infrastructure, there are still organizations where you can connect with others to begin to understand what the opportunity might be. And so just this group would be a great opportunity to connect APPs that are interested in research, or our professional societies that are in pulmonary and critical care medicine can connect us with each other. So I think brainstorming with folks who have some research experience to think about, what is your clinical question? What are you interested in? And then what shape does that take? Is a good way to start. I think the first thing that I would have considered a little bit of research myself was learning simply how to do the logistics of data entry for a randomized trial we were doing years ago. And then also, how could I think about the process and then maybe write an abstract with some of the data from that. So I did, and then it sort of snowballed from there in terms of my understanding of the logistics, what might be other research question opportunities, and then how to be clear what I know and what I don't know so I can keep learning about how to do research.
Do you think that somebody needs to be a research expert to be able to start this process?
Oh, for sure not. I mean, I think I would never label myself as an expert, right? I've been privileged to be mentored by so many incredible clinician researchers, and the privilege of getting to know so many people from other organizations that I otherwise would not know. But now I see them at conferences and we all know each other from our monthly Zoom research meetings for years. And that in itself is so professionally satisfying because I feel like I could call many of them and brainstorm about research or another professional question. Hey,
Mm.
how do you do this in your ICU? How can we make things better here and there? So there are operational brainstorming that comes from this. And so I think just the network has been invaluable for me as an APP. And I think something that we don't always have through only um, academic organizations, right? Like we really want to connect across those settings. So we can, all of us, no matter our work setting, can contribute.
Do you have suggestions for how, you mentioned there are research networks. Is this something that can be found online, or how can somebody get involved in that type of network so they have somebody to talk to and potentially do research with?
Yeah, good question. I think it is finding, for us as APPs, it's finding other APPs who are doing it and having,
Mm.
even one-on-one conversations to brainstorm. I think also depending on the physician you work with, you may have physicians involved in research. And I have to say, like, not all of them will think top of mind. My APP colleagues can contribute to this. But our organization has developed this bias, right? That in our practice, we've been sort of as APPs, the consistent one, making sure that we execute in a high quality way and all of that. That's a culture thing for sure. But I think as APPs interested in this, we can create that culture, right? Like
Right.
wasn't here before we did it at Leahy, and we just move forward with very supportive and engaged physician colleagues who were super supportive, and then also from a randomized trial perspective, ended up in a network has a genuine desire to be pragmatic and inclusive, and I think that
Mm.
matters a lot.
Yeah, definitely. Do you have any suggestions for somebody or resources that you know of for maybe there's an APP who wants to just develop their research acumen? So not just have that connection with other people interested, but also just learning more about maybe how to do research themselves and develop that process.
Yeah, great question. There are some just some logistics that in every organization you would have to go through to participate in research. So there are going to be some online learnings likely that your IRB would have you do to be able to participate. And actually, when you've never gone through those before, the learning is invaluable. So they're really purposeful to make sure that you understand the regulatory infrastructure for research and what we can and should do in research and what we can't and shouldn't do. And I found the first time I went through that process to be really enlightening and helpful, and of course then
Mm-hmm.
facilitating me being allowed to participate in research. So if your organization has an IRB, it will also have a connection to those resources that you would have to do to participate in your organization. But also, in any of our professional societies, there are connections to research infrastructure and or others who are doing research and sometimes even projects you can get involved in. So without naming any particular group, any of them would have to some degree.
Mm-hmm.
So I think that's a way to get additional learning, either from maybe there's a talk at a conference about it, or maybe there are online modules in society to say, here's how to think about trials and so I think the first step is sort of figuring out what does your organization require you to do to be able to participate, and that will provide the learning. The other thing is for those of you who work in organizations that have residencies and fellowships, most commonly those have structured learning for the residents and fellows to learn how to do, the basics of research, how to think about an abstract, how to think about their first manuscript. And so I'm a deep believer, this goes a little bit to my director of advanced practice day. Let's not be redundant, right? Like we're all learning,
Right.
we're all learners. And so the basics being taught to residents are perfect for the basics to be taught, to us as APPs or to an attending physician who's never done research before. So if you've got that infrastructure, tap into it. So that's a good opportunity.
Yeah, I think that's a great opportunity that honestly I didn't even consider myself. But as many of us who went through PA school and P school, if they weren't doing our PhD track, we really weren't taught much research,
Totally.
unlike some of our physician colleagues, and so that would be a great resource is, to just kind of develop that foundation.
Yeah.
Um, so I want to just thank you so much for your time. But before we go, do you have any questions that you think I should have asked? Any information that you want to offer for this topic of just kind of encouraging more APPs to get involved in research?
I don't have any questions, but what I would sort of summarize to say that, mm, again, it's super important to me to reiterate how rewarding this has been, not just this trial, which was a pretty amazing trial, right? But the journey to the trial, just as important. The
Mhm.
connections, learning from other clinicians, how I've been treated as an APP in this research group cannot be understated. How important that is to me and my professional development and learning and how welcoming the group has been. With that comes for any of us who care about doing a great job in what we do, a desire to knock it out of the park. And so, to me,
Mhm.
the more I became involved in this, it just builds on itself. And I have found that to be invaluable and satisfying. Also want you know, I think my colleague, Jana Landsberger at Vanderbilt, and she, uh, in our professional and personal relationship, has always been super supportive of me from another organization. Learning from her and the structure that they have at Vanderbilt. So I also just need to make a shout out. This is all about
Mhm.
connections and learning from people that know how to connect you to other things. And the best advice we can give to listeners is just start doing that if you're interested. And there are also people out there who research is not for them. But I think the message, if you don't want to do it yourself, that's totally okay. But you can be a very proud, up to date APP, knowing the
Mhm.
evidence, whereby
Absolutely.
at the bedside, you are improving outcomes for your patients. So there's a whole continuum of how involved in this you can be. But at the very least, our charge is to be really great at knowing the recommendation for our critically ill patient in that moment.
Absolutely. And so I've just been so impressed watching you through this process, and I constantly am learning from you. So thank you so much for teaching me prior to this podcast, being involved in my professional development. But also thank you so much for sharing your time today. I hope that more APPs are encouraged to be up to date, to implement research that we know is going to improve patient outcomes. And so thank you so much for your time. And for those who are listening, don't forget that you can claim your CME for listening to today's podcast. If you look in your show notes, there should be a link there that will tell you how to get to claim those. Additionally, if you're interested in hearing more about APAP or being involved in the critical care committee, go to the pulmapp.com website and you can submit an email or share your interest, and we will definitely connect with you. And as always, please like, subscribe, and follow to help support APAP. Thank you so much for listening today, and I hope you have a great week.